Onc Live Insights is a video editorial program produced by Onc Live.
Ibrutinib is an inhibitor of the Bruton's tyrosine kinase, BTK, and it's in that context that it's used to treat B-cell malignancies. However, it turns out that ibrutinib is not a very specific inhibitor of BTK. It actually inhibits approximately 19 other kinases with IC50 less than 100 nanomolar, and 7 of them have the cognate cysteine to which it binds covalently in BTK. That therefore means that ibrutinib has the potential to inhibit a number of other kinases covalently, just as it inhibits BTK covalently. The kinase that has been most studied in terms of its ability to be inhibited by ibrutinib, other than BTK, is a kinase called ITK, which is normally expressed in T cells. In fact, ibrutinib has been shown to covalently inhibit ITK, and the impact of this has been studied in mouse models of CLL, where it's been found that this inhibition of ITK actually can restore some of the skewed T cell balance that's normally seen in CLL. And in fact, this resulted in improved resistance to infection amongst the CLL mice that were challenged with certain pathogens. This has therefore led to speculation that perhaps some of the activity of ibrutinib is not directly due to the effect on BTK and CLL cells, but may also be due to restoration of improved T cell function amongst patients with CLL. We know that CLL cells themselves actually inhibit the activity of T cells through a direct interaction, and there are probably other pleiotropic effects inhibiting the immune system as well in CLL. So a therapy that would actually restore immune function in CLL would be quite impressive. Ibrutinib dose in CLL was selected to be 420 milligrams daily following the initial phase 1, whereas 560 milligrams daily went forward in lymphoma. The BTK occupancy data suggests that both of those doses result in quite high BTK occupancy in the majority of patients. The question has arisen whether dose intensity is important for ibrutinib and if it matters how compliant patients are in taking the medication. There is an abstract presented at ASCO 2015 looking at dose intensity for ibrutinib in the context of the RESONATE trial. And in this study, it was found that, in fact, the likelihood of relapsing on ibrutinib was higher in patients who had missed a higher percentage of doses. Thus, it is important to maintain dose intensity with ibrutinib, it seems. Ibrutinib has recently been approved by the FDA for any relapsed refractory CLL patient after at least one prior therapy, as well as for 17p-deleted CLL in both an upfront and relapsed setting. Ibrutinib has rapidly moved into the relapse space for most CLL patients, regardless of risk status, although probably its extra benefit is seen most in the higher risk patients and those with short durations of remission to their prior therapy. An aspect of this is, of course, the activity in 17p-deleted CLL, where we know that in the relapse setting in patients with a median of 4 prior therapies and 17p deletion, the median progression-free survival with ibrutinib is 28 months. Now, this is less than the progression-free survival of ibrutinib in any other subset of CLL, but better than any existing reported data for this patient population. In fact, better than any existing reported data for upfront therapy of 17p-deleted CLL, which is why ibrutinib received an indication upfront as well as relapsed in 17p, although at present there's very little data in the upfront setting. Ibrutinib would be the treatment of choice for any 17p-deleted CLL, whether upfront or relapsed, based on the median progression-free survival in relapsed patients of 28 months. That being said, the 17p-deleted patients do tend to relapse earlier on ibrutinib than other patients, and one therefore does need to think about potential consolidative strategies still in patients who are candidates, such as young, fit patients. These patients could be considered for potentially curative allogeneic stem cell transplantation. The importance of this is also highlighted by the fact that patients relapsing on ibrutinib to date have had very poor outcomes. Two studies recently reported, one from the Ohio State University and one from MD Anderson, looked at outcomes in ibrutinib-treated patients and found that their overall survival was really quite poor. In part, this was because half of the patients relapsed with Richter's transformation. But even those who relapsed only with CLL were difficult to salvage. In fact, in the MD Anderson study, any patient who relapsed on ibrutinib, the median overall survival for that group of 33 patients was 3 months.
Bendamustine rituximab plus ibrutinib demonstrated a far better response rate and a far longer progression-free survival than bendamustine rituximab plus placebo. And while it's unclear to me that you really actually need the bendamustine or rituximab to generate the response and the duration of the response, it certainly shows that the chemotherapy can be combined safely with ibrutinib and that these agents remain safe and effective. In relapsed disease, I think it's certainly important to use our best, it's always important to put our best foot forward. And if a patient hasn't received idelalisib or ibrutinib by the time they've relapsed, it's definitely important to use it at that point in time. When we talk about using an agent in combination with chemotherapy, or we talk about using an agent in relapsed disease, based upon the FDA recommendations, that's really based upon the trials that were pragmatic and capable of being done and enabling the data to be generated in real time. The goal is always to get novel, better agents to our patients sooner, and those are how the trials are designed. When it comes time to actually choosing a therapy for our patients, I always believe in giving my patients the best therapy. And it's not important as to whether or not there's an FDA-approved indication for that therapy. What's important is that it's the best therapy for our patient.